Hey, future respiratory therapist. So today we're going to dive into hypovolemic shock. So we'll be kind of going over the vital signs, mechanical ventilation parameters, how the patient will present, imaging, ABG results, and just a little bit of everything. So yeah. So hypovolemic shock can be broken up into two different types. We have hemorrhagic and non-hemorrhagic. So when you think of hemorrhagic, think of bleeding due to trauma, excessive anticoagulant use, or maybe some other type of medication. So usually hemorrhagic, think hemorrhaging, right? Um, Maybe someone goes into uh, expectant mother goes into labor and has some type of increased blood loss that is detrimental to her well-being, and she starts hemorrhaging. Think hemorrhagenic shock. Non-hemorrhagenic shock is kind of all the other, can be all the other underlying shock factors that play into hypovolemic shock. So with this type of shock, it is really important to listen and understand and pay attention to what the patient is saying. So let's say a patient comes into the ER and they're vomiting profusely. Their significant other mentions that they've also been having diarrhea throughout the day. And they're starting to feel very lightheaded, very weak. This has been going on for three days. Maybe the nurse is trying to figure out what medication might be causing it, or what medications they're on that she can relay to the doctor that are causing the diarrhea. But as of this present moment, the patient's blood pressure is low, their oxygen is desatting, and they're starting to get confused. They're not really remembering what they just told you. So it's really important to look at vital signs when we're dealing with hypovolemic shock. It can kind of come on or present out of nowhere, and then it will progress sometimes from, very minor to very urgent in a short period of time. Here we see there are four main classes of hemorrhage, starting with class 1 and then going all the way to class 4. The main difference is the loss of like the percentage it goes up, so like 0 to 15, 15 to 30, and so on. The hard thing about this is that the initial stage is just very minimal tachycardia and decreased capillary refill. So a lot of times this can often present as anxiety, and the patient may be taken or looked at as just being anxious, and then it gradually increases with, tachycardia, tachypnea, decreased blood pressure, loss of urinary output, and to the point where it is a noticeable change, loss of consciousness. So these are just good to know and things to look out for progressively for hypovolemic shock. So when it comes to imaging, it can really vary depending on, one, the severity of the shock, and then also the type of shock. So typically they'll do a CECT first, and it kind of goes and identifies like the abdomen, pelvis, like those major areas, to kind of see where the blood loss is. And then from there, they may do like an ultrasound or an echocardiogram to kind of see where the blood has congregated to. They could do an endoscopy or something else along those lines to try to identify like a GI bleed or something else to that effect. I actually got to see this recently, so I was at one of the hospitals or for a clinical this week, and we had a patient that had a potential GI bleed, and so we brought them down to CT, and they did a CT, um, and the sonographer was pretty adamant that they needed to call the doctor and let the doctor know the patient had a GI bleed. So I did include a picture of a CT. To be honest, I'm not very good when it comes to reading or identifying CT scans. It's just not something that we really have gone over that much in school so far. And also, it's kind of a specialized part of like radiology. However, I did think this picture was cool because it really shows you the difference or the change, which is easy to identify. Um, so yeah. When it comes to hemodynamic monitoring for hypovolemic shock, really all of your pressures are going to be decreased. So like your CVP, your PAP, your PCWP, um, your cardiac output, everything will be decreased because there's a lack of volume, right? The only thing that's going to be increased is your systemic vascular resistance because it's harder for that to take place systemically because of the lack of volume. Um, so you'll definitely see that when it comes to CVP, the normal value is 2 to 6. So typically they say less than 2 millimeters of mercury that shows a loss of blood volume hemodynamically. I also included just some other key points. Specifically, when you're looking at like blood pressure, it's usually less than 80 systolic. You'll probably see an increase in heart rate and definitely an increase in respiratory rate or increased work of breathing because the body is trying to compensate. Something that we can do as respiratory therapists is ensuring that the patient is properly oxygenated. Obviously, if there's an increase in blood loss, there's probably going to be a decrease of oxygenation to the tissues, which is also going to decrease oxygenation to the vital organs. So we're going to want to make sure that the patient is properly oxygenated. So either like a high flow O2 or mechanical ventilation if necessary. We'll go into the parameters and stuff in a little bit regarding what settings to put on the patient on for mechanical ventilation. But some other things that we can do is initiating like lactated ringers. Sometimes when the patient will initially come to the ER, nursing will give a bolus of fluids just to kind of amp up for what they've lost. If the patient is a class 4 shock, they will need crystalloid and type O blood. I think type O blood is the universal donor, and that is why it says type O, but those are just some other key points. So often what we can see in hypovolemic shock is a metabolic acidosis. Obviously, the patient's pH will be decreased, showing that they are acidotic, and they'll often have a decreased bicarb. Sometimes their CO2 will be kind of elevated because it's trying to compensate. But it just kind of reflects what the body is doing, right, to try to get itself back into homeostasis. So it can vary depending on the level of severity or the class type that the patient is currently in, but typically it will present as a metabolic acidosis. Sorry that the font on this is kind of small. I really tried to adjust it to make it easier to read, but it still is kind of difficult, so my apologies on that. So when it comes to mechanical ventilation, we really want to avoid positive pressure ventilation, mostly because when a patient is hypovolemic, they already have a decreased venous return, a decreased cardiac output, and then they're usually hyperventilating to try to compensate for that. And so by putting them into positive pressure ventilation, it'll cause an even greater decrease in venous return and cardiac output because of that intrathoracic pressure on the greater vessels. So we really want to be careful with that. When it comes to good parameters to put a patient on for mechanical ventilation, I couldn't find a whole lot on this. I kind of just tried to go off of like logically or clinically what I've seen. Um, and so I know with pressure control, it can help the patient, or PCAC, help the patient be more hemodynamically stable. So I figured that would be helpful. Or I've seen before at St. Thomas West where they'll put the patient on ACVC plus because it'll help balance the blood gas. So I thought that may also be helpful to help manage that patient's blood gas or get it back into a more positive um, ABG value. So in conclusion, we went through some of the key findings when it comes to hypovolemic shock. Oftentimes that can show in a low blood pressure or low hemodynamics, such as low CVP, PAP, PCWP, and decreased cardiac output, and an increased SVR. We can also see some x-ray or CT changes, specifically in the case of like a GI bleed, where this can present. And then some other key things we went over were ABG values. Oftentimes hypovolemic shock will present as a metabolic acidosis. And then key points to remember for mechanical ventilation is to not put the patient on positive pressure ventilation, as this will hurt the patient more than help them. And we can utilize pressure control or PCAC or VCAC plus to help with hemodynamic stability or to manage the blood gas. Lastly, I've just included my references. These are really the same sources that I utilized for the last video. It was mainly just a comprehensive textbook and then also the MedSafe website that was provided.